Okay, we're all on the right page. Okay, so my name is Julie. I went through the program here in, trying to think, 2011, okay. And I've worked here at the hospital since 2009 in the lab. You guys were probably all in middle school in 2009, if not elementary school. I don't even know how old you are. I'm very old. Okay, I'm very old. It's Botox, it's sunscreen. I'm elderly. I'm 37, guys. So I've been here a while. What? Oh, thanks. I don't have kids. That's what does it. Don't have kids and you'll look like this, right? And work afternoons and evenings your whole life, never see the sun, and then you'll look like this. Okay. So I don't work in the main lab anymore. I did it for about 8 years. I've been in microbiome for the last 5 years, but I did do urinalysis even as a student. Even first out the gate as a student, they're like, you want to do urines, you go for it. They gave me 1 week of training. They're like, you're good to go. Of all the areas in the lab, we want to take our time. We want to be very cognizant of, patient identifiers, not getting stuff mixed up, taking our time. Of all the areas in the lab, urinalysis is the one place. If you make a mistake, no one is going to die because you got their urinalysis incorrect. Blood bank, yes, you cannot make a mistake in blood bank. Someone will die. Urinalysis, like we always try to be completely error-free. But if you switch urines, if you give someone the wrong urinalysis, it is an important test, is not life-threatening, basically. So don't freak out when you start doing labs. Don't freak out when you're working in the lab and you're confused about urinalysis. No, it's good. Don't worry. It's fine. They let me do it as a college student, okay? It's fine. We're good. We're good to go. So why do we do urinalysis? We do it to screen for diseases of the urinary tract and kidneys. So some diseases of the urinary tract that we're looking for are UTIs, kidney infections. Diseases of the kidneys can be glomerular nephritis. That is where a UTI is untreated for so long, it goes up into the kidneys and infects the glomerular structure. We're also looking for metabolic and systemic diseases. So an example of a metabolic disease could be diabetes. A systemic disease could be liver failure. We can also detect that if it's bad enough in a urinalysis. We also use it to monitor a patient's condition. And I just told you all this. When we get a urine from the patient, we want to look at the color of it, how clear it is, if there is any foam present, and the odor. And that is the part no one likes. But it does tell us a lot about the urine and about the patient. Some of them, you get them out of the tube, like the pod, you'll smell it. Through the bag, it's double bagged, you're going to smell it. And you're like, this person has a UTI, I don't even need to test it. I've had those. They're gross. Okay, our color. What determines color? It's mostly concentration and pH of the urine. The color reflects the hydration and metabolic state. And you should probably know this. Urochrome is the pigment that gives the urine its characteristic color. At least when I was a student, that's a question they asked. Urochrome. Okay, so we can get colorless urine. That's not uncommon. It usually happens if they have diabetes, where they're drinking so much water, they're essentially just peeing it all out. Overhydration. I've gotten some marathon runners who drink so much, they have water intoxication, they come in, pee straight water essentially. It usually has a very low specific gravity. I also have a note here. This happened to me. This was a real case. What's a non-biological cause of dilute urine? Toilet water. We had a patient come in for a drug screen. They didn't watch him urinate. He just dipped his cup in the toilet and sent it up. You can tell it's toilet water because it will have a specific gravity of 1. Even in the worst renal failure, Your kidneys are not going to give you a specific gravity of exactly 1. It's always going to be above 1. If you have a specific gravity of 1 and a drug test is also ordered, it's always prudent just to call the floor and say, did you actually watch this patient give the sample? If they say no, say, I highly recommend a recollect. I think it's toilet water. And I did it, and they recollected, and of course, his drug screen just like lit up. So it was like everything was positive. It's like, bro, you're not fooling anyone. Okay. I've never seen this one. It can be white or milky. I've never personally seen it. I think it's more common in older people. It can be caused by a lot of white blood cells. Usually this is someone who is chronically bedridden, or they're in like a long-term care facility not receiving good care. For it to get that bad in an ambulatory patient, that would be extremely uncommon. Fat can also cause it. So I took some notes on this because I've never run into this. Apparently lipiduria can cause white or milky urine. And so I looked it up, and that can be caused by Crush syndrome, which can lead to kidney failure. That's if you're in like a bad accident and like your fat tissue gets like, I guess, ground up or really damaged. Chyluria can also cause it, which is a milky lymphatic obstruction. Okay, yellow is normal urine. Riboflavin can also cause yellow urine. That's one of the B vitamins. It usually gives it a much brighter color. So if you get a urine that's almost a little fluorescent yellow, that's nothing to be alarmed about. Usually it's a patient who is taking supplemental B vitamins for a vitamin deficiency. It can be dark. That's usually concentrated, and it will have a high specific gravity. Now, I have seen brown urine that can be high in urobilinogen, bilirubin. Have you guys learned about the porphyrias yet? Okay, so porphyria can definitely be something. Phenol poisoning apparently can cause that. Drugs, aloe, fava beans, rhubarb. So do you know much about urobilinogen? Did they go over that a little bit? Okay. So it is a colorless byproduct of bilirubin, and it's formed in the intestines and eliminated in the urine and feces where it gets its color. Higher or lower levels can indicate liver disorder, red cell destruction, or a gallbladder blockage. Bilirubin it's red-orange, and it produces the brown urine, but only conjugated bili is water soluble. Red urine can be red blood cells from a UTI. It can be menstruation. It can be myoglobin from a muscle injury, or rhabdomyolysis, which is where the patient kind of attacks its own muscles. Myoglobin, you may have gone over this already. It's the protein that stores oxygen in muscle tissues. Once it's released into the bloodstream, it can cause tubular obstruction, and it can damage your kidneys. Lead and mercury poisoning can also cause red urine, and of course beets. That's very common, but that's more of a pink color. I've also never seen this color, brown or black urine, caused by methemoglobin. That is the form of hemoglobin that can carry oxygen but can't release it into tissues. Homogentistic acid. So if people have something called alkaptonuria, their body doesn't produce enough of the enzyme that breaks down the homogentistic acid, and their urine will turn black when it's exposed to room air. Melanin can cause brown black urine, and so I found this interesting. You won't have to know this, I just thought it was interesting. If melanin is present in urine, it usually signifies malignant melanoma. I've never run into that, but I just thought it was interesting. Tyrosinosis can also cause it, and certain drugs. The one I found, a few I found that can cause it are methyl-dopa, which they give for preeclampsia, Flagyl, which is used to treat bacterial vaginosis, and Senna, which is used to treat constipation. Let me know if I'm going too fast or you want me to repeat something. Sorry, I did not make this PowerPoint. They just gave it to me, so. I've never seen green urine. Bilirubin can cause it. That's a product of heme catabolism. That's what causes bruises to be green. Oxidized bilirubin can also cause it. Phenol poisoning. Certain drugs, and the drugs I found are promethazine, which is used for nausea. I've taken that before. Cimetidine, that's a heartburn drug. Amitriptyline, which is one of the first line antidepressants. Propofol, which is an anesthetic. Well, they use it in anesthesia. Methylene blue, which is a dye, and then other food dyes can cause it. Indicans, which is found in small bowel infections, and Pseudomonas. Has anyone, you guys haven't done micro yet, right? Okay. So Pseudomonas aeruginosa is a gram-negative rod. And when it grows on some of our clear plates up in the lab, it does turn fluorescent neon green. So if you had a UTI with it, you can get green urine, apparently. I'd be very concerned if my urine was green, like going to the hospital concerned. Orange, blue, and gray. Once again, I'm real scared. So orange urine, anytime it's orange, it's usually the brand name is Azo, and the generic term is oh my gosh, I have some with me right now. Let me Google it because I'm going to tell you what it is. Because it's important, because you'll see it a lot. Phenazopyridine. It's PHENAZOPYRIDINE. That is what that. So when you get you'll get a urine. It'll be like construction cone orange, and you won't be able to run any of the chromatogenic tests on it because it's going to turn every pad orange. That's an over-the-counter drug. It is a dye, but what it does is it is an anesthetic for your bladder. So a lot of people use it when they have UTI or interstitial cystitis. They can use it until they can get to a doctor to be treated. It's very common to see in an outpatient setting, and that's the only cause of orange urine. So when you see that, just know there's nothing wrong with the person. That's what they have, and you'll have to cancel the color portion of you'll have to cancel the dipstick portion of the urinalysis, but you can still do the microscopic. It doesn't affect the microscopic or the urine culture, just the color portion. Blue can also be caused by other drugs, and gray can be caused by drugs. So clarity just means how clear is it, and we usually grade it from 1 to 4, whereas in this case it looks like it would be 0 to 4. So clear is transparent, it looks like water. You can put like a sheet of paper with writing behind it and you can read through it. 1 is a few particles, you can still read behind it. 2 is cloudy, you can see that there is writing, but it's blurred. 3 is turbid, newspaper cannot be seen, and 4 is milky, completely transparent. It might even be clotted. And then those are some examples. So the one on the left would be like a very well hydrated patient. Middle is normal urine. That's probably either a UTI or something else causing the red color. And then the one on the far right is either chyluria or a severe UTI that has been let go way too long. So what causes turbidity? It can be increased red blood cells, increased white blood cells, non-squamous epithelial cells. So if the patient either has a lot of vaginal discharge or hasn't cleaned well, a lot of the squamous epithelial cells will get into the sample. We have children here. It's a children's population, so they are not good at cleaning. I mean, we try to instruct them how to do a clean catch, how to collect a sample appropriately, but trying to instruct a 3-year-old how to do that, it's not going to go too well. We just accept what we get. Bacteria can cause it, yeast, crystals, and lipids. You guys gone over microscopic yet for urines, like the crystals and everything? Okay, so non-pathological causes. These are things that are not going on within their body that are wrong. Mucus threads, increased vaginal secretions again. Talc powder, especially in our children's population, we get this all the time with little kids. They use talc powder for diaper rashes, and we get it in the sample. Squamous epithelial cells, semen or sperm, that can also be in the sample. Fecal contamination, if you have a children's population or you're dealing with older adults who are incontinent and they're in diapers in the home, sometimes you'll get fecal contamination. You'll have non-pathological crystals. You can get X-ray contrast media. So a lot of people will get X-ray dye if they're getting CAT scans like with and without contrast, or urograms with and without contrast. They'll take the CT scan first, then inject dye into the person, take the scan again. And then it takes about 24 hours for the dye to leave your system. So if you give a sample within that time, you can still have some of the dye in your urine. And then vaginal creams. The other thing we can find in urine is foam. If it's white foam, that means protein is present, which is made up of albumin. Albumin decreases the urine surface tension, which causes the foam. And damaged kidneys allow the albumin to enter the urine from our bloodstream. Yellow or black or brown foam is caused by bilirubin. We don't report foam because the reagent strip has protein on it, so it's going to detect any protein. And urobilin will produce no foam. Odor. Normal urine has a faint ammonia odor, completely normal. I didn't realize this until I started doing research. There is actually no known cause for that odor. It's of little clinical significance except in cases of or rare disorders. So these are some disorders where the scents could give you a clue about what's going on with the patient. I actually had a kid with maple syrup urine disorder. So he was in the NICU. So maple syrup urine disorder, it is autosomal recessive. It is the buildup of leucine, isoleucine, and valine. And it is detected in infants. I think it's on our newborn state screens in Ohio. But so I got his urine from the NICU, and I opened it up and I started doing the urinalysis, and I was like syrup. And I'm like walking around to everyone in the lab. I'm like, here, smell this. They're like, what? I'm like, Church, smell this? And they're like, oh yeah, it does. It smells like syrup. So of course we're like, let's go on this kid's chart, see what's going on. Yeah, he had maple syrup urine disease. I just thought it was interesting. I mean, it has no real significance to me, but so ammonia, if you get an ammonia-like scent, means the specimen's over 2 hours old. We want to try to do testing on specimens if they're less than 2 hours, but I mean, that rarely happens. We have outpatient labs, and some of our urines are 14 hours old by the time they get here, so it's just whatever. If it's ammonia-like or foul, it's a UTI usually. You know the scent. Once you smell it once, you'll know it. If it's sweet or fruity, that can mean the patient has ketosis from diabetes. If it's musty, that can be phenylketonuria. That is where patients lack an enzyme that breaks down phenylalanine. That is included in the newborn state screen in Ohio. If it smells like bleach, that can be contamination. There's nothing normal about bleach smelling urine, so that could mean that they use toilet water from a toilet that has been recently cleaned. And then if it smells like sulfur, that can be either be cystinuria or homocystinuria. And the homocystinuria is a defect in an enzyme that breaks down methionine. So a lot of those are just inborn errors of metabolism. Got some more. If it smells like beer, that is methionine malabsorption, which is also known as host house disease. Rotting fish is trimethylaminuria. You guys don't have to know any of these. They're not going to ask. Cabbage and fish, it's tyrosinemia. Sweaty feet, methylmalonic acid. I don't know how you would differentiate between like cabbage, rotting fish, and sweaty feet. Rancid butter and who is? I don't know who's coming up with this. Like, this is sweaty feet. This one's rancid butter. If you, I guess the view from 40,000 feet is if you get a urine and it smells very strange, it's probably an inborn error of metabolism. There's something going on with the patient. Okay, so there are usually two parts to urinalysis. The first is the chemical analysis. So we do the dipstick, and then it is the microscopic analysis where we actually look at it either in the analyzer. The analyzer will look at it and take a bunch of photos, or we look at it under the microscope, and that is looking for cells, debris, bacteria, or crystals. So on the chemical strip, the chem strip, it tests for all of these. It will test for protein, glucose, ketones, bilirubin, pH, hemoglobin, nitrates, urobilinogen, white blood cells, and specific gravity. When we do the microscopic examination, casts, I forgot, we're looking for casts. And that is, so casts are kind of like the inner lining of your renal tubules sloughing off and going into your urine. It's caused by like kidney damage. White and red blood cells, crystals, and then bacteria, yeast, and trichomonas, which is an STD. So quality assurance for urinalysis testing. It's 3 different phases: pre-analytic, analytic, and post-analytic. Pre-analytic, it begins on the floor. You got to ID the patient, do proper specimen collection and handling, proper labeling, and complete the requisition properly. This is a really big issue that I've noticed in the hospital. I think, you know, there's just a shortage of nurses and CNAs on the floor, and they're overworked. You will get, it's very common to get unlabeled samples, or samples where you'll get a urine and it says like Bob Smith, and then you'll get the requisition and it's like Frank Jones. So then I have to call and be like, then I'm like, okay, well, whose nurse do I call? So you have to look in the computer, and then, okay, Frank Jones had a urinalysis, or whoever had a urinalysis. Then I call his nurse and I'm like, okay, did you just send me a urine on Frank Jones? And she's like, well, yeah. I said, okay, it has Bob Smith's label on it. So is this Bob Smith's urine, or is this Frank's urine with Bob Smith's label on it? And she'll be like, I'm not sure. As far as urinalysis goes, just have them recollect it. They have to recollect it. That is an easily obtainable sample. I had a nurse one time tell me, and this was a patient on the psych unit, so they were not physically impaired. There was no physical impairment. They sent it unlabeled, and I said, hey, you sent me an unlabeled sample. I just need a new one. I wasn't even going to write them up. I was like, I'm cool with this. Just, I'm going to throw it away, pretend I didn't see it, just send me a new one. And she's like, what if he doesn't go again? And I was like, what do you mean? And she goes, what if he doesn't pee again? And I said, well, I was like processing it, and I was like, well, I don't think he should be on the psych unit then. He probably should be like in ICU if he's not going to pee again. They like to act like it is the end of the world. Patients that they had to cath, I get that. That's understandable. That is a traumatic, especially if it's a child, especially if it's an infant. But you still have to do your due diligence, and that's one of the hardest parts about the job, calling the floor and saying, hey, it's unlabeled, because you're the bad guy. Even though they're the one that messed up, you're the bad guy. And they hate you for it. And they're going to give you attitude. And sometimes I've had the charge nurse call and say, you know, this patient's going to die if you don't run this. And it's like, sorry, if it's that critical, you need to make sure you are labeling it. So, and this is where it starts, the pre-analytic on the floor when they're labeling it. We teach them, and when people are doing phlebotomy, we teach them, you take the patient label in the room with you. As soon as you get those tubes of blood, you slap a label on it before you do anything else. I do not care what is happening. Even when I went on traumas, as soon as I got those tubes of blood, a label went on them. Like, that should be, fill the tube, put the label on. That should be like 1, 2. Never do one without the other. For all of you, when you're going to be doing your phlebotomy, never do one without the other. Bam, bam, 1, 2. Because I've seen them like fill tubes of blood and then just sit it on the counter in the patient's room, and I'm like what is this? Like, why? At the very least, even if you don't have their label, take a Sharpie and write. Like, we can accept anything in the lab as long as they have 2 identifiers. I do not care how the identifiers are on there. You can write them. I don't care, but they have to be on there. Sorry, that's my speech for the day.
I laughed because the other day I had a blood work come up, and the one tube had 2 different labels on it.
Yeah.
And they're like
patients.
patients.
I'm like, how do you do this?
It was from ER.
How do you do this?
And I called them, and the girl I told them I had to put these 2 patients in the reflex. I don't know whose blood this is.
Yeah.
And all she knows is, oh.
Half the time they're like, can you just run anyway? I'm like,
No.
Now, there are certain tests, like here, our pathologist allows us to submit like a request to run certain tests that are not retrievable, like a bone marrow, a CSF. We're not going to make these people get that done again. A blood culture if they have just initiated antibiotic therapy, because you can't reproduce that state. A biopsy. Like, I'm not going to make them, oh, sorry, you're going to have to take this patient to surgery again, do a brain biopsy again. No. But if it's such a critical sample, I would be like quadruple checking. Is the label on? Is it the right patient? Okay, let me send it. Is the label on? Is it the right patient? Okay. They don't. Yeah.
Yeah, we had a nurse for support gas actually heard. No, they use the label from the mother instead of the baby. So
That I feel like is a gray area.
they need to send an attestation form because it's orgas.
Yeah.
But yeah, I mean, like, obviously it's so random, but it's just.
Yeah, that I would say, because it came from, it's not the best practice, but that I could see putting in a like exception request for. But no, when it's like completely different people, I'm just like, what? Okay, the analytical section. This is your responsibility. This is when your responsibility starts. You have to make sure You're correctly IDing the sample. And you have to make sure the sample matches the requisition like we were talking about. You have to make sure that the sample is appropriate to test. It can't be too old. We have had samples that were like, 36 hours old and they still want a urinalysis tested. Well, if the patient is in-house and you can get another urine, no, we're not doing this. In rare cases, like if the patient is outpatient and they can't come back, yeah, sure, that's fine, whatever. You have to make sure there's adequate volume. Here at our facility, we can run it on 1 cc or less because we are a pediatric facility, so we're able to run most of our tests on very small volumes. Adult facilities probably have much larger minimum volumes, and it has to be in the proper container. I can't tell you, I got urine in a pickle jar once. It was a plastic pickle jar. That is not a proper container. That is not a sterile container.
We get pill bottles.
Yes, pill bottles. You can't do it if there are interfering substances. Sometimes we have 24-hour urines, and to preserve the urine, there's like acid added to the jugs. We can't run a urinalysis off of that because there's already acid in the jugs. That's going to interfere with it. You have to make sure your reagent strips have been properly stored. They can't be stored open because they can absorb moisture from the atmosphere, and that can mess up the results. And you always want to follow safety procedures and do quality control as many times a day or shift as your facility warrants. And then post-analytic. You want to get the patient results out as quickly as you can, especially for patients in the ER, because you want to get those results out so that they can go home or be treated. You don't want them rattling around there for 12 hours. Then everyone gets cranky down there. And you want to compare them with previous test results. This is where you might find urinalysis is one of those tests that can change wildly from collection to collection based upon what they've eaten, what they've had to drink, what they've done that day, but so just compare as best you can. When you're doing a urinalysis, you want to wear all your PPE, gloves, lab coat. I don't wear safety goggles. That's a bit of an overkill for me. Most places have face shields. Just know that you are working with large quantities of urine, so there is a splash risk. I have a coworker, she no longer works here. I'm going to tell this story. I told her I was going to tell this story. She had a 24-hour urine and she was shaking it, and they have graduated markings on the side, and she held it up to look at the marking and the top fell off and it just hit the floor, and she's like, I got a 24-hour golden shower. And yeah. And then she had to drive home pee soaked and take a shower and change her clothes and then come back to work. So just I would be more cautious in urinalysis than other areas, just because you're dealing with larger volumes of liquids. And I have definitely spilled urines on the floor and gotten some pee splashes on my shoes. Thankfully, it was just my shoes, but just cautious because you're dealing with larger quantities than like chemistry or hematology, where it's just like a tiny little tube. We also use biohazard trash. If a spill occurs, just use bleach, wash your hands frequently, and as with every area in the lab, no food or beverages, at least as long as the manager's not kidding. No food or beverages. The best specimen collection is random or the first morning void, depending on what the doctor's looking for. We can do 12-hour urine collections or 24-hour urine collections. It can be fasting. It can be postprandial, clean catch midstream. We can do a suprapubic aspiration. We have to do that for some people that either can't be capped or have anatomical difficulties. Maybe they have a urostomy bag or a catheterized sample. Oh, cystoscopy is also another one. I forgot about that. Cystoscopy. If you work in a hospital, you will get some samples like that. That is where they take they think that there might be an issue with the patient's bladder, so they take them into surgery and they put a small camera up the bladder, and they can also take a urine sample at the same time. At least in micro with cystoscopy, we treat that a little differently. We use a larger urine loop so we can capture more of the urine on the plate, and we consider even one urine colony as a positive. Okay, so your random or your routine void, it's sufficient for most routine urinary screening. That's how we do drug screens. It's very easy to collect. You don't have to have the patient do anything. You can detect like gross properties like glucose, protein. It is not a great metabolic screen, especially if they've been, if they haven't been adhering to like a diet the doctor wants them to do. Results could be altered or diluted due to increased fluid intake throughout the day. And this one is not acceptable for urine culture. We have our first morning void. I don't know why it says this is the specimen of choice. This is the specimen of choice for urinalysis. Let's put it that way. So clean catch, that CCMS stands for clean catch midstream. That is where you have, they'll give you like a little package of wipes and you want to cleanse the area, urinate a small amount, and then put the container in your stream of urine without breaking the stream. That's what clean catch midstream is. A collection immediately after awakening is preferred for obtaining non-contaminated specimens. This is the one we like to use most for pregnancy testing because this is going to have your highest concentration of HCG. So obviously, if you're like 8 weeks or more along, it doesn't matter because you're going to have enough HCG in any urine sample that we're going to detect it. If a doctor is trying to catch a very early pregnancy, like if someone's having fertility issues or he thinks that there is a threatened pregnancy, like a threatened miscarriage, he's going to want to do a first morning void where you haven't urinated for like 8 hours. Some of the cons, there are some people that have something called orthostatic proteinuria. It affects 2 to 5% of adolescents. It's usually absent after age 30. And that is where patients have increased urine protein levels while standing, but they're normal when laying down. You look confused.
Just weird.
Oh yeah, it is weird. So if we did this in a patient that had this, we would miss it because the first, you know, if they're normal when they're laying down, they're going to give the first morning void. You're not going to have protein in your urine, but you're going to miss the fact that they have this because they're not doing a random protein throughout the day. So we could do a 12-hour urine collection. You guys have done chemistry already, right? Okay, so you know what the BUN and creatinine ratio are. It measures BUN and creatinine ratio. It is a good monitor of your kidney function. It is an inconvenience. You have to follow collection procedures and you have to keep it refrigerated. We can also do a 24-hour urine. We use this for creatinine clearance to determine how well the kidneys are eliminating waste. So you have to start this one with an empty bladder, which sometimes the patients are very confused about. You don't start this first thing in the morning. First thing in the morning, you go to the bathroom. Then it starts. You do not do your first morning void into the 24-hour urine collection. You're going to void in the toilet and then record the morning time. That's the start of the test. And then obviously don't throw it on yourself like poor Kiwi did. So a fasting urine is used for the detection of diabetes. They want the second voided specimen after fasting. That keeps the form elements intact and doesn't contain any metabolic samples before fasting. You can also do postprandial after you're eating. That is used for the detection of diabetes. So you're going to go to the bathroom right before you eat. And then you will give a sample 2 hours after eating. And if you have diabetes, you should have glucose in your urine at that point. Then the clean catch midstream. This is what we use for urine cultures. So you're going to cleanse the area with soap or water or a little towelette that they give you. You begin to urinate, then you put your urine cup in the stream without stopping the stream, collect some, and then you can void the remainder in the toilet. This is the only way we do bacterial and cultures, except for cats. Sorry, or suprapubic aspirates. This is where you insert a needle directly into the bladder. A doctor will do this, and it's usually done in surgery or on a patient who is sedated or otherwise incapacitated. Oh yeah, I'm so sorry.
Is there a way to get urine from each kidney? I had a nurse a few weeks ago bring 2 urines from the same patient, and she said like one was from the left kidney and one was from the right kidney.
Yes,
And they look different.
yes.
Like,
They do that in surgery. They run line, not really lines, but they run like a tube through your bladder into each ureter, and they can collect urine from each kidney. I don't know. I would imagine it is to test to see, like they're testing to see if there are casts in one kidney versus the other kidney. Because I'm trying to think, because like if they're trying to look to see if, or maybe they're trying to see if there's bacteria in one kidney versus the other kidney.
Bacteria can actually go all the way up to the kidney.
Yeah, they can.
the urine definitely has 2 different colors.
Yeah, it would be. So they're probably either the person was a transplant patient, or they're trying to determine if one of the kidneys is infected or damaged at some point. But yes, they can, because I've seen that before too, where they'll bring a urine from each kidney, but they can only do that in surgery. Maybe they could do it with a needle aspiration, but I really think they would just do that in surgery. Gosh. I don't want that done to me, okay? Let's just say I don't want that done. I've gotten suprapubic aspirates. Those are pretty rare. I think they like to avoid doing that. It's traumatic to the patient, so we can use that. It's great for cultures, and we also can do cytology on it, where we spin down a sample and we can look for like tumor cells or unusual like bladder lining cells. Catheterized urine, tubes inserted through the urethra, no contamination. The urine is considered sterile. It needs to be done correctly, and this is used if the patient refuses or cannot go on their own. So the urine containers that we use, they have to be clean, dry, and disposable. They're usually plastic with a screw top lid. For infants, we have little baggies that you can actually attach to their genitalia and just let them like void into the bag. We have a brown or orange jug for 12 and 24-hour urine. You have to have the name, date, time on it. You need to put a sticker or some type of notation if preservative is added, and it should be delivered to the lab as soon as possible. If the urine cannot be processed within 1 to 2 hours, it has to be refrigerated in a dark area or mixed with an additive in order for the constituents to stay intact. And BD, that's the company, actually makes Urinalysis Vacutainer preservative tubes. We don't use them at this facility, but I know other ones do. And that's for long-term storage, like if a specimen can't be processed for 14 hours. Bilirubin and urobilinogen cannot be preserved this way, though. Refrigeration and freezing do not interfere with chemical tests, but they do prevent bacterial growth for 24 hours. It raises the specific gravity and it precipitates amorphous phosphates and urates. Those are clinically insignificant. So if you have a urine with a pH over 7, they're phosphates. If the pH is 7 or under, they're urates. It's just a weird artifact. If the urine gets too cold, you'll get like this layer at the bottom sometimes of like junk. And then if you heat it up in a water bath, they go away. So we can also acidify the urine. It preserves protein and formed elements. It does not interfere with routine analysis other than pH. Bacteriostatic, so it keeps bacteria good and healthy. It does interfere with drug and hormone analysis, and large amounts may precipitate into crystals. We can add formalin. This is what they use for histology samples. It's excellent for preserving cells and casts. It does interfere with copper reduction tests for glucose. Well, I think we go over that in our next slide, or our next lecture. It can cause clumping of sediment. We can also add toluene. Does not interfere with routine tests and floats to the surface of specimens and clings to pipettes and testing materials. Toluene actually is not effective if bacteria is present in the sample, and I did not realize that. Bacteria must interact with it in some way. So we have a thymol addition. This preserves glucose and other elements well. Does interfere with acid precipitation tests for protein. Large amounts of the preservative will interfere with some glucose tests. Now, phenol doesn't interfere with routine tests, but it does cause an odor change. Okay, and then just some miscellaneous tidbits about urine. It is 96% water and 4% dietary intake and waste products. If it's clear, colorless, and you've got large volumes of it, it usually has a very low specific gravity. If it's dark and a little hazy, it usually has a higher specific gravity. Urinary output increases as we age. Decreased volume usually means increased specific gravity. We talked about this before. Urochrome is the primary pigment that gives urine its characteristic color. And urochrome is a waste product from hemoglobin degradation. Okay. So these are some terms used to describe issues people can have with their urination. You'll see these as diagnosis codes. Nocturia, that is increased urination at night. That's common among the elderly because there's a decreased ability of their kidneys to concentrate urine, and it can also be a sign of diabetes. There is a diurnal, and this is not a diagnosis code. There's a diurnal variation, so that means your urinary output increases or fluctuates from day to day. Anuria, this is a diagnostic descriptor. That is when production of urine is absent. It can be a sign of dehydration, renal failure, or obstruction of the urinary tract. Oliguria is decreased production of urine, and that can be due to any of the reasons listed above. Polyuria is increased levels of urine production. It's frequent urination. It usually appears in conjunction with polydipsia, usually normal, but it can be a sign of diabetes or diabetes insipidus, where the patient doesn't truly have diabetes but has an increased thirst. So we were talking about specific gravity, and I'm sure from your chemistry classes in college, a bunch of you still remember what it is, but we'll go over it again. Specific gravity is the ratio of the weight of a volume of urine to the weight of the volume of water at a constant temperature. So we're just measuring how much that urine weighs versus how much the same amount of the water weighs. It's used to you just have to know it is used to measure the concentrating and diluting ability of the kidney. The lower the specific gravity, that means the closer to water it is. Water has a specific gravity of 1.0. And these are the reference ranges. A random urine usually has a specific gravity between 1.003 and 1.035. 1.035 is the upper limit of what the kidneys can do. That is how concentrated the kidneys can make your urine. And a 24-hour urine usually has a higher specific gravity. It's 1.016 to 1.022. Hypostenuria is decreased specific gravity between 1.001 to 1.003. Some causes could be diabetes insipidus, glomerulonephritis, or pyelonephritis. It's clear to light urine. It's gonna look very similar to water. Isothenuria is 1.010. Specific gravity is neither greater nor less than that of protein-free plasma. It reflects chronic and acute renal failure, and that is where kidneys lack the ability to concentrate or dilute urine. So I want to make something clear. If you have one urine sample that's 1.010, that does not mean you have isothenuria. We're talking about this is what your specific gravity is all the time. Like every time you give a urine sample, it is always 1.010. And then there's hypostenuria, which is increased specific gravity of greater than 1.020. It can be from dehydration, chronic heart failure, diabetes, nephrosis, and you will usually have dark yellow urine. So how do we do some of these tests? The majority of the chemical tests are done on the test strips. Most are qualitative, just present or not. Some are semi-qualitative. Some are quantitative. And the method is comparable to more specific methods. It's pretty accurate. And that's what they look like. So to do your dipstick, you want to take a well-mixed specimen at room temperature. You don't centrifuge these. You're going to dip all the pads into the urine and then kind of pull it out. And as you're pulling it out, you want to kind of like, just like bring it against the side of the container so you get all the urine off, and then lay it down on a flat, clean surface. And you're going to compare the color changes to within the reaction time. I think most of them are 60 seconds and the white blood cells are 120 seconds. QC is usually performed every 8 hours, but it's going to vary based on your institution. They're convenient, they're cost effective, they're very stable, they're disposable, they're single use. They can be done with a relatively small volume of sample. If you only have 1 cc, you can use a pipette and just pipette it onto each little pad. They're easy to clean up, and you can either read them manually or on an automated strip meter. So this is a picture. The top one is the refractometers that we use now. You'd put a little bit of urine in like that little clear area, and then you look through the eyepiece, and you have like this little look through the eyepiece. You have like a up and down, like what do I want to say? It's like scored markings for the different specific gravities, and your urine will go up to where the specific gravity is. I'm sure you'll see it next door. I'm not explaining it. And then this goofy thing. That is, I've never used that thing. That thing is so old. I think that's an old school refractometer. The teacher that taught me, she was like 75 years old. And she was like, I remember back in Minnesota in the 1950s, we used this. And I was like, okay. So no place uses this anymore. The person who made this lecture just wanted an example. These were really old school refractometers. You would stick a large amount of urine in there, and then it had like a hollow glass bulb that you would stick in there, and it had like a measuring stick up at the top, and wherever it like ended up floating was where your specific gravity was. But you needed a huge volume of urine to do it, which is why it kind of went out of. And you had to like calibrate for the temperature of the room you were in. It was a mess. Okay. So the refractometer method, this is for specific gravity. It compares the velocity of light in air to the velocity of particles in the solution. So we went over what specific gravity is. That is basically how much does the urine weigh compared to how much water weighs. And what determines that is how many particles are in the urine compared to how many particles are in pure water. And from physics, you know, if you have light going into a solution that has a lot of particles, you're not going to get much light coming out of it. If you have light going into like a cup of pure water, you're getting a lot of light coming out because it's not getting absorbed by all the particles in there. Refractometer is very similar. It measures the total solid in a solution by using a prism. It's an indirect method. It's rapid. It's very simple. You use a very small amount of urine. You don't have to correct for temperature adjustments. You don't have to correct if there's a high amount of protein, and it will measure between 1.002 and 1.035. So to measure the specific gravity, we're kind of doing those old school experiments from like high school chemistry. We're shining a light through the urine, and I'll show you what it's going to look like when you're looking through. When you're looking through the refractometer, this is what I was trying to explain. You have like a chart. So if I was looking through the refractometer, I would say that the specific gravity is 1.014 because that is where the light hit. This is just what we went over, the refractive index. It's a measure of the dissolved substances in solution, determined by the ratio of the velocity of light in air to the velocity of light in the solution. The refractometer is used to determine this, and it corresponds to the specific gravity. It's an indirect measure, but that's how we do it. The urinometer. That was that goofy thing down there. That's what that was called. Okay. So the urinometer, it looked like this large, I don't think we even have one anymore. It looked like this large graduated cylinder, and you would put urine in it and then put like a bulb in, and wherever the bulb stopped floating, it would have a little measurement on the stick, and that is what the specific gravity would be. But you needed a large volume of urine. It was temperature dependent. The urine had to be at room temperature. You couldn't read it if the urine was turbid. It doesn't correct for temperature, glucose, or protein. The ball could change in size, like the ball on the little float. And you had to calibrate it every day with water. So once they had a new method, they were like, we're going to scrap this. And this just went over what we were talking about. It was a mercury weighted glass bulb. You put the bulb in the urine and spun it. It was free floating. You read the scale at the lowest point. If the temperature in the room was below 70, you subtracted 0.003 for every 10 degrees below 70. If it was above 70, you added 0.003. I would just go over this in case, I don't think it's going to be a question, just in case this is a question on the test about how to correct for a urinometer. I really don't think they would, just because it's such an old method. I would hope they're not going to ask about this. Another test we can do on urine, and we're almost done, guys, is osmolality. So osmolality is the number of milliosmoles per kilogram of solvent. This is really taking you back to chemistry. It is the concentration of the particles that are dissolved in a fluid. It's used to help evaluate the body's water balance. It can be increased with chronic heart failure, hypernatremia, liver damage. I don't know what SIADH is.
When you have too much ADH.
I don't know it. Let me Google it.
Syndrome of inappropriate ADH.
Oh, yeah, you're probably right. Wi-Fi. This Wi-Fi goes down all the time here. Yes, syndrome of inappropriate antidiuretic hormone secretion. Okay. So your osmolality will be decreased with diabetes insipidus, excess fluid intake, hypercalcemia, hypokalemia, kidney tubular damage. It can also detect the presence of toxins such as methanol and ethylene glycol. So they will often order osmolality for patients who have brain injuries, because those patients, the brain injury will cause their sodium to increase, and the increased sodium in their blood will increase their serum osmolality. So you can do osmolality on urine and on serum. And if they have increased sodium, their urine osmolality and their serum osmolality will both increase from all the sodium in their system. It's an indirect method of measurement. So you measure the freezing point of solution, since the freezing point is proportional to the amount of particles. The reference range for urine is 250 to 1200 milliosmoles per kilogram of water. And then serum is 275 to 298 milliosmoles per kilogram of water. It measures the capacity of renal tubules to concentrate urine. So the main thing to know is that you detect this by freezing point depression. So the way this works is your sample is super cooled below the freezing point, and then the machine is going to vibrate so that air bubbles are introduced and crystallization occurs. So when you run the machine, you put the sample in, and then you hear it go like dirt, 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 and that's it vibrating. So the air bubbles are introduced and crystallization occurs. Then after crystallization, the heat of fusion, which is a byproduct of the vibration, is released, which causes the sample to start heating up. And then the sample is going to heat up until an equilibrium is reached, where some sample is frozen and some is still liquid. And the temperature at which that equilibrium is reached is the freezing point. So the freezing point is that unique temperature at atmospheric pressure where the solid and liquid phases coexist in equilibrium. So you have to supercool it several degrees below its freezing point and then mechanically induce the sample to freeze, and that's the vibration. The heat of fusion is liberated, which causes the sample to start rising, and then you're going to get an equilibrium where solid and liquid exist at the same time. So there's two ways to measure it, either the osmometer, which we talked about, or you can do a calculation usually using the patient's sodium, glucose, and BUN. This is just an estimated value. So this is not commonly done or currently done. I think this would only be done if you don't have access to an osmometer. I would know that calculation. That is the end of the first one.